My name is Karen Geisenberger. I am a ThyCa volunteer and a 17-year medullary thyroid cancer survivor. I had sporadic, and I'm here just to host this session, management of chronic disease. It's session 323, just to make sure you're in the right session. And we are honored to have Dr. Danica Vodopivec. I didn't say it right. Vodopivec. She is an oncologic endocrinologist and assistant professor of medicine at the University of Alabama at Birmingham, Department of Endocrinology, Diabetes, and Metabolism in Birmingham, Alabama. After obtaining her medical degree at Universidad de, can't say it.
Guayaquil.
In Ecuador, she completed an internal medicine residency at Leahy Clinic, Tufts University in Burlington, Massachusetts. She did her endocrinology fellowship at Boston Medical Center, Boston University School of Medicine in Boston, Massachusetts, followed by an oncologic endocrinology specialty fellowship at the University of Texas MD Anderson Cancer Center. Throughout her training years, she has participated in clinical and bench research dedicated to parathyroid, neoplasia, Meltkin endocrine neoplasia syndrome, and tyrosine kinase inhibitors, resistance mechanisms, and thyroid cancer. Her scholarly activities have resulted in several peer-reviewed articles, book chapters, and quality improvement projects dedicated to better serve the community of patients presenting with various types of endocrine neoplasia, in particular advanced thyroid cancer. Welcome, doctor, and I'll turn it over to you.
Thank you, Karen, for your introduction. First, I want to start by thanking ThyCa for the invitation. I really feel honored to be here and, have the opportunity to enhance patient education on a topic that I'm so passionate about. So let's start by discussing the topic. Topic of the talk is medullary thyroid cancer, medical management of a chronic disease. So I would like to start by indicating where is the thyroid, very basic information. Basically, the thyroid is a butterfly-shaped gland that is located in our anterior neck, just in front of the trachea or windpipe. And it is composed of two types of cells. The first one being the follicular cells, which basically produce and secrete thyroid hormone. And the second type of cells are the parafollicular cells, which produce calcitonin and carcinoembryogenic antigen that I will refer as CEA. So medullary thyroid cancer originates from the parafollicular cells of the thyroid gland. And because of this, calcitonin and CEA are going to be the tumor markers for medullary thyroid cancer. Okay, so medullary thyroid cancer is a rare type of thyroid cancer. It accounts 2 to 5% of thyroid cancers, and it can be either hereditary or sporadic. Hereditary means that you will inherit it from one of your parents. Okay, so it means this type of cancer runs in your family, and it is part of the multiple endocrine neoplasia type 2 syndrome, where it's not only your thyroid that is involved, but also glands are involved in this and affected in this syndrome. Okay, and because it's inherited, it means that the mutation that make the cancer appear will be present in all the cells in your body, because it's embedded in your DNA. You inherited this from your parents, and that mutation is called the germline red mutation. And we say germline because you inherited it. Then the other type of medullary thyroid cancer is sporadic, which is the most common one, and it accounts for 75% of medullary thyroid cancer cases. Sporadic means that you didn't inherit this cancer from one of your parents. It means that it happened spontaneously. It's sporadic. And the mutations that are the most common mutations that are part of the sporadic medullary thyroid cancer are red. But remember, this is not germline red. This is a sporadic red. And it's present in 50% of sporadic medullary thyroid cancer. And the second most common mutation is RAS mutation, present in 15%. So because it's sporadic, this means that these mutations are going to be found only in the medullary thyroid cancer cells. The rest of your body will not have these mutations, okay? Now, because of this, it's very important when patients are diagnosed of having medullary thyroid cancer, the patient should undergo genetic testing and make sure that, you know, there's not a hereditary condition going on. Because if it were to be identified that you have the hereditary medullary thyroid cancer, your family members need to be tested, right? And the hope is that they get tested even before the medullary thyroid cancer have arise. So, you know, you decrease morbidity and mortality in your family member, okay? So the next question is, how does medullary thyroid cancer present? And most of the time, I would say that medullary thyroid cancer is asymptomatic. Sometimes you can see a bump or lump in your neck, and in less frequent occasions, it will present as having compressive symptoms. So what is compressive symptoms? Compressive symptoms means that you have a tumor, a mass in your neck, and it's making you have difficulty swallowing. When you lay flat in bed, you feel shortness of breath because there's something here compressing at your neck. You have a dry cough, or you've noticed changes in the tone of your voice. Your voice becomes hoarse. So any of those symptoms could be considered as compressive symptoms when there is a mass in your neck. Other symptoms that can be also less frequent are diarrhea and flush. Okay, those could also be related to medullary thyroid cancer. Now, the evaluation of medullary thyroid cancer is made during the clinic visit with a physical exam, imaging, and laboratory evaluation. Okay, so here you can see a graph where there's different time points from initial diagnosis, being here in yellow, to the surgery, where the surgeon came and removed your thyroid and any other lymph node that had the cancer, to your first postoperative visit, which usually takes place 3 months after your surgery. And this visit, as any other visit, is very important because here is where we want to see your for the first time, your calcitonin and CEA levels after the surgery. Okay, and we will hope for them to be undetectable because in theory you don't have a thyroid gland anymore, or within normal limits. If they are above limit, it means that, you know, there is a set of medullary thyroid cancer cell that was left, right, from the surgery. Then the second postoperative visit takes place at about 6 months after the first one. And everything after the second postoperative visit, for the purpose of this talk, I would like to call it long-term monitoring, okay? And this is where my talk will develop. So there are 3 monitoring steps, 3 basic monitoring steps for medullary thyroid cancer for the monitor, which is measuring calcitonin and CEA tumor markers, doing the proper imaging studies, and making sure that the patient is taking the thyroid hormone replacement treatment, right? Because if you don't have a thyroid anymore, you are dependent on taking the levothyroxine or the thyroid hormone medication for the rest of your life. Now, I do want to, okay, I'll explain that later. So let's just move on for now. So let's talk about calcitonin and CEA, which are the 2 tumor markers. So as I mentioned earlier, the parafollicular cells will secrete both of them. What is the difference, you know, between calcitonin and CEA? So calcitonin is very specific to medullary thyroid cancer. It means that only the thyroid cancer cells that have the tumor will produce it, okay? It's very variable. What does variable means? It means that if you go to the lab today morning, you will get one number. If you go to the same lab later today, you will get a different number. It will be kind of similar to the first one, but it's not going to be the same one. It's very variable. And it also will be different from one lab to the other lab. That's why usually we like to tell the patients to always try to have the calcitonin and CEA markers drawn at the same lab, so that we kind of, go around this variability of calcitonin, and we are better able to assist in interpreting the value. Okay, so also because of this variability, the interpretation of the calcitonin should not be focused on a one time point value, but rather on its trend. So what is it doing along the course of time? Not just because of what happened one single time, okay? And to avoid the false elevations of calcitonin, it should be collected while fasting, avoiding heavy meals or alcohol the night before the test. And also the lab work should be collected before the imaging studies. Keep this in mind. Why? Because the contrast media of the imaging studies can make the calcitonin levels falsely look elevated. Okay, now in regards the CEA, this is a less specific tumor marker. What does this mean? Less specific means that CEA is not only produced by the parafollicular cells of medullary thyroid cancer. Other cells in our body will also produce CEA, right? This is the reason why if the person has any lung, prostate, or colon disease, CEA can also be elevated in these conditions. So we need to keep that in mind. And it can also be elevated in people that are smokers, okay? And it's, on the other hand, it's less variable than calcitonin. So this means that if you go to the lab, you will probably today morning and then in the afternoon, you will probably get around the same number, okay? And we need to keep in mind that both of them, calcitonin and CEA, need to be collected at the same day because we need to interpret them in the same day. That's the way we can interpret the results, okay? So before I continue into this slide, I want to make sure that we all understand what means biochemical evidence of disease and what is radiographical evidence of disease. Okay, so biochemical evidence of disease means that your calcitonin and CEA are elevated, right? It's a biochemical diagnosis. As opposed to having radiological evidence of disease. That means that when we do an ultrasound, a CT or an MRI, we are able to see disease in different sites of your body. So there is radiological evidence of disease. Sometimes patients might have biochemical evidence of disease. So we see that calcitonin and CEA are high, but when we do the radiographic studies, we're not able to see disease, right? So this means that this patient has biochemical evidence of disease, but there's no radiographical evidence. Basically, this means that it just takes time for the tumor to be able to be seen, from going to microscopic, needing the microscope to be able to see it, all the way to it being going to macro for us to be able to see it under the scans. So I just want you to take a note of that, because I've noticed and I understand patients getting very worried about saying like, doctor, but my calcitonin, my CA, they are elevated. Where is the tumor? I don't see the tumor. You've done CTs, MRIs, neck ultrasounds. Where is it? Well, you know, it's microscopic. We're not able to see it right now. It will take time for it to show, and that's why you need to keep coming to do your monitoring, and we need to take care of that, okay? It will develop, but it will take more time. Now, when we're doing our monitoring, we can see different trends of how this calcitonin and CEA can behave over time. In this first example, we see where calcitonin looks in red and CEA looks in blue. And we see a straight line at and below the normal range. So basically, both are not rising, and they are below the limit of normal of the lab parameter, or they are within range. And when this happens, this is a very good prognosis. We say that there is a 10-year survival of more than 95%. And there is a 3% chance that the calcitonin and CA will begin rising within 7.5 years. The second trend that we can see is a slow pace of rising, where the calcitonin and CEA tumor markers are slowly rising over time. I would say that this is probably the most common that we see in patients, and it just tells us that this tumor is slowly growing, is slowly progressing. We just need to keep an eye on it. It's not behaving aggressively. It's an indolent condition when it's having this type of trend. Then the third one is a rapid pace of rising of both the calcitonin and CEA. And of course, we worry about that, right? Because it means that the tumor is growing in a faster manner. And the fourth pattern is this very interesting one, where there is rising of the CEA levels compared with a slowly rising, declining, or stable calcitonin levels. You see how there is discordance, and this CEA level is going, trending up really fast. And this is not good. This is an indicator of a poor prognosis, and it's just telling us that this medullary thyroid cancer is undifferentiated. It's not behaving as it should behave. It's not producing a lot of calcitonin, and that we don't like to see that. But remember that I said earlier that CEA can also be elevated in other conditions. So the endocrinologist needs to think, okay, I need to make sure this patient doesn't have a colon cancer or some lung cancer. Make sure that this CEA disproportion elevation, it's not coming from another condition, and it's just because of the medullary thyroid cancer being very aggressive and undifferentiated. Okay, so how do we go when it comes to calcitonin levels and what imaging studies to order? And the answer of that relies on how high your calcitonin level is. When your calcitonin is less than 150, we say that there is disease in the neck. And this disease can be either persistent or recurrent. What is the difference between persistent and recurrence? Persistent means that the surgeon removed the tumor, and after the surgery, the tumor, there was tumor still there. There were, microscopic cells that, surgeons do not have a microscopic eye to see, oh, I left one cancer cell behind, right? So the tumor was persisted after the surgery, the cancer, as opposed to recurrent. Recurrent means that the surgeon removed everything out, and with time, the tumor came back, okay? So when the calcitonin is less than 150, we think that there is disease in the neck. And the proper image study to order will be a neck ultrasound. There's no need to look for disease in the lungs, in the liver, or anywhere else. Why? There's no need to expose the patient to further radiation with a CT when the disease is localized to the neck. Once the calcitonin is more than 150, this is when we start to worry about having distant metastatic disease. And when this happens, then we will order the neck ultrasound alternated with a CT of the neck. We will order a CT chest with contrast to look for if there's metastatic disease in the lungs. We will order a CT or an MRI in the abdomen to see if there's disease in the liver. We will order a pelvic MRI with or without a bone scintigraphy to look for if there's a metastatic disease in the bones. And There's also this newer test called DOTA-TATE PET scan, which we order when the tumor markers are rising and the conventional like ultrasound, CTs, MRIs are not able to find lesions that are growing or are not able to find new lesions. So when this happens, we order this more, I would say, detailed test called DOTA-TATE PET, and this is particularly a good test to detect bone metastasis. Because remember, medullary thyroid cancer, the first place that it likes to travel is to the lymph nodes in your neck. Once it does metastasize to distant areas, it likes to travel to your lungs, to your liver, and your bones. So these are the first things that come to our mind when we try to look for a metastatic disease. And something that I would really like to highlight is that the PET scan that everyone talks about, right? When somebody have cancer, you hear about people having PET scans, but this is not the DOTA-TATE PET. This is what we refer as to FDG PET. So this type of PET scan is not really recommended in medullary thyroid cancer because it's not really good at detecting disease. Okay. Then predictors of poor survival. We have the calcitonin doubling time being less than 6 months. So what is the calcitonin doubling time? Is basically collecting calcitonin values, and then you go to a specific website and you put in that website the different calcitonin values that you collected over time, and through an algorithmic process, this website will tell you how much time it's taking for your calcitonin to double. And to be able to have like a very good estimate of the doubling time, you will need to collect the calcitonin at least every 6 months for a 2-year period, so that you will have a more accurate result when you have a total of 4 calcitonin doubling calcitonins to upload into the computer system. Another predictor of poor survival is having extensive disease with a very low tumor marker. So here it doesn't make sense, right? If we see many metastatic sites under the scans, we should see tumor markers that are really high. But when we see this disproportion, it is also a predictor of poor survival, because it's telling me that medullary thyroid cancer is no longer producing too much calcitonin, too much CEA. It's becoming undifferentiated. And the last one is the scenario that we already talked about, that the CEA is rising much more rapidly than the calcitonin. So now let's talk about the management. How do we manage this persistent or recurrent disease after the initial surgery? If we know that this disease is localized to the neck, then the first thought process will be, okay, so I have new disease that is popping up that have shown in my neck, so I just need to go to the surgeon and have it removed, right? That's our first thought of process. Let's just take it out, right? But when this happens, we usually don't jump into removing it. Why? Because as long as the new lesions that are popping out are not compromising, are not affecting your vital structures, and by that I mean they're not invading into your trachea or your windpipe. The new lesions are not invading your esophagus, so they are not causing you trouble swallowing. As long as they are not invading those vital structures and they are slowly growing, they are not really harming you. So when this happens and they are slowly growing, we just like to monitor. Maybe you won't come back every 6 months. Maybe I want to see you in clinic every 3 months. It just depends. And we will monitor to see how fast they grow. If they start growing fast, then we will go ahead and talk to the surgeon and say, let's go and remove this lesion. But also, as we kind of monitor the pace of growth of this lesion, maybe new lesions will pop up in the neck. And now, you know, it won't be like this person will end up having multiple neck surgeries because every time something new appeared, we just jump onto taking it out. So by just giving it a little bit of time, new lesions will also show, and the surgeon will not just come and remove the lesions that we are able to see. The surgeon will actually clean the entire section of the neck, of the affected neck. And by this, we prevent recurrent surgeries. And at the end, you know, it's not fun to have surgeries. This is painful, right? So besides that, I would like to talk about what are tyrosine kinase inhibitors. When do we need to start chemotherapy when it comes to medullary thyroid cancer? And for that, I have this graphic over here where graphic A, the red over here is the tyrosine kinase receptor. So tyrosine kinase receptors are, as the name says, receptors that are localized in the superficial part of our cells. Okay, there needs to be a molecule that binds to this receptor so that this receptor becomes active. Once the receptor becomes active, there's a downstream effect into the cell that promotes cell growth and proliferation. The problem is that when there is cancer, there is a mutation where these tyrosine kinase receptors are mutant, and they no longer require a molecule to bind to them in order to be active. They are autonomously active. They are always active. They don't need this molecule anymore. They are active all the time, and all the time they are sending the message for cell growth and proliferation. So this cell is just continuously dividing and, you know, being cancer. Now, the tyrosine kinase inhibitor is a chemotherapy that we take by mouth, and what it does is that it blocks this altered tyrosine kinase receptor, and by blocking it, you block cell growth and proliferation. Okay. However, I do have to mention that many patients with distant metastases have indolent, slow-growing, slow progressive disease with a stable or slowly rising calcitonin and CEA levels. And when this happens, these patients just require active monitoring without the need to start systemic therapy, hopefully for years. And why we want to be careful on not being fast or being easy to give these medications. Why? Because this decision is not taken lightly. These drugs cause toxicity, meaning side effects, right? If there's a tumor that is slowly growing, you just know it's in your body because we're doing CT scans and ultrasounds, but you don't have any symptoms from this. It's not harming you, right? So if we start giving you a drug that now you will have nausea, you will have fatigue, you won't feel like yourself, you know, why are we making you feel unwell when, you know, the tumor was not even growing that fast? It was not harming you. So, you know, toxicity is one of the reasons why these drugs should be taken lightly. We don't want to change your quality of life when it's not needed. Also, these drugs are not curative treatments. They will basically make your tumor stop growing, or in some circumstances, it can make your tumor shrink a little bit, but they won't make your tumor disappear. Also, once you start on these medications, you need to take them all your life, right? Except, of course, if you are getting toxicity from them or they stop working and the tumor just starts growing even when you're taking the medication. But once you we make the decision to together, you know, patient, doctor, multidisciplinary team, that you're going to start a medication, you take it for the rest of your life. If a big commitment, also because you have to, your visits with the doctor are going to be more frequent. And also when you take them for a long time, the tumor will learn a mechanism through bypass the blockage. So what we call drug resistant and drug resistance, and the drug will stop working basically because the tumor learns how to overcome the drug being there. Cancer can be smart. Now, what are the indications then to start these treatments? When there is advanced, unresectable, meaning you cannot take it out with surgery, and rapidly progressive. This is a key, rapidly progressive medullary thyroid cancer. Now, there are two types, I would say 4 different medications that are divided into 2 different categories. Over here in brown are the first type of medications, the ones that were first FDA approved, and hence they are older, and they are called multi-kinase inhibitors. Multi-kinase inhibitors means that they block different tyrosine kinase receptors in the cell. They are not specific to target one, they target many. And these drugs were FDA approved in 2011, 2012. They are vandetanib and cabozantinib. The other group are the selective RET inhibitors. These were FDA approved in 2020. And they are selpercatinib and pralsetinib. Now, these medications only target RET. They do not target RAS or any of the other mutations. They are only meant to be for RET mutation, and they are, as the name says, they are selective. They are potent because they will only target RET, and because they are selective, they are better tolerable. They cause less side effects when it comes to vandetanib and cabozantinib. These drugs are very well tolerated, but still can create side effects. The most common being elevated liver enzymes, so causing a little bit of harm in your liver, elevated red blood cells, decreased white blood cells, so being prone of having like infections, and they can also cause nausea. But again, this doesn't happen in everyone. These are things for us to look up when you are on these medications, but overall, people don't even feel they are in the drug. So bottom line is, if we know that once we know we're going to start or you're getting close to starting chemo, tyrosine kinase inhibitor, we want to check what mutation you have. If you have a RET mutation, then we will start the first line of treatment, which is selpercatinib or pralsetinib, a RET inhibitor. If once the RET inhibitor stops working for you, then you have the other options of switching to a multi-kinase inhibitor. On the other hand, if you don't have the RET inhibitor, then you will start with the multi-kinase inhibitor and go from there. Now, overall, I think people that start these drugs, they probably have, these drugs probably work for an average of 2 years, but I've seen patients that are taking these drugs for 10 years, especially the multi-kinase inhibitors, because these are the oldest ones, and are still doing fine. It just depends on how aggressive your tumor is and how it behaves. Everyone is different. And there are other therapies like immunotherapy, CAR-T immunotherapy, tumor vaccines that are not FDA approved for the treatment of medullary thyroid cancer, and they are still under clinical trials and being studied. So they are not a part of the treatment as of now. They are not part of the conventional treatment. Thank you very much for your attention, and please let me know if there's any questions.
Thank you, doctor. We do have a couple of questions. The first one I have is, does doubling time use the result from before surgery as the number to double?
No, only after surgery. We want to see the behavior of your tumor after the surgery, yes. So let's put an example based on what I said. basically your first calcitonin will be collected 3 months after surgery. So that will be the first calcitonin to put in the app. Mhm.
Okay, and what is the doubling time period? Just as an aside from that.
Yeah, so the doubling time period, basically, so your question is how to get it, or what does it mean? Or what do we need to collect to get it?
What, so when you're looking at you're looking at the doubling time over the how long it takes.
Okay,
And
perfect.
then
Yeah, so for us to be able to get the most accurate doubling time, we need at least 2 years, because you need a total of 4 calcitonins, and we usually collect them every 6 months. So it will be 2 years to get a better estimate. You can get it sooner, but it's not going to be a good estimate.
okay. And I have another one. Thyroidectomy for medullary 3 years ago. At the time, it was more than 15,000 calcitonin and 400 CEA stage 4B. Now the calcitonin is 300 and CEA 12, stable for 2.5 years. Taking 150 levoxythyroid. Question: should I keep the TSH on the high or low range for better management?
Oh, that's a great question. Thank you for the person who did that question. So I need to clarify something. Medullary thyroid cancer is different as the type of cancer that develops from your follicular thyroid cells. Those are, that's another type of cancer, okay? Those are papillary thyroid cancer, follicular thyroid cancer. Those are different types, and those are the ones where we need to keep our TSH below the normal range, keep it suppressed. But in medullary thyroid cancer, we don't need to do that. Your TSH needs to be within normal range. There's no need to suppress your TSH.
Can you do labs for calcitonin the day after a bone scan, or is this too soon, and will it cause a false elevated calcitonin level?
Yes, I would prefer doing the calcitonin and CE level before the bone scan. And if you already did it, then I will wait probably 5 days to get it.
What group of drugs does Retevmo belong to?
Okay, so Retevmo belongs to the second generation, the RET inhibitors. That's Retevmo.
If step 1 in treatment appears to be surgery, then why wait when more neck evidence comes forward? Why not just clean out the compartments when it appears? You go after it fast and then just watch. Why? Then why not just watch? I'm not sure I'm reading this correctly.
But I think I understand the question. I think it's saying, like, if cancer is showing in my neck, why I'm gonna wait for it to keep growing? Why don't just go and take it out? I think that's the question. Why waiting sometimes can be better? I think that's the question. And that's because we prefer waiting when the cancer is not growing into your trachea, when the cancer is not growing into your esophagus, so it's not really harming your vital structures in the neck. If that's not happening, and the cancer is, let's say, I do have to say that your first surgery had already happened. So this is for more surgeries to come. We're not talking about the initial surgery. We're talking about once you have had the first surgery and now there is recurrent of disease. That's the scenario that I'm talking about, okay? So in that case, if, as I mentioned, the tumor is not growing into your airways, not growing into your esophagus, it's slowly growing, and let's say you had a surgery 6 months ago, right? A neck surgery 6 months ago, and now we see there's tumor there. We don't rush the surgery. We would prefer to wait, see how fast this grows, because if it's growing slow, it's not harming you. We need to wait. And perhaps during that waiting time, more lesions will pop out. And so the surgeon can do a better cleaning of the neck. That's what I'm referring to.
Thank you. Okay, so the next question. After my total thyroidectomy 10 months ago, I started having 10 to 15 hot flashes, not flushing, per day. I've taken Synthroid dosages from 137 to 88 with no improvement. My endo does not feel that this is thyroid related. Who can I see to help me with this?
Well, we need to see there's a differential diagnosis that fall into that. In the case of this particular patient, I don't know her age, but having postmenopausal symptoms can make you feel like that. So if you're in the menopause, that can be a reason why. I will need to know the age of the person.
She's 70.
She's 70. Okay, so that means that she underwent menopause probably a long time ago, right? And okay, then it's not menopause. Then if the endocrinologist cannot find a reason for this, I will send you back to your primary care doctor and try to go from there. We need to rule out it's not an endocrine problem. Once we do that, you need to go to your PCP.
Thank you.
You're welcome.
Okay, once TKIs stop working on multiple bilateral lung nodules, is lung transplant the next option or the next step?
No, as a general rule, organ transplants are not recommended for any type of cancer. Why? Because once you get a lung transplant, you will receive medication that will lower your immune system. So once you're on this medication, your cancer can explode. We don't do that. Transplants are not recommended in people that have thyroid cancer, just as a rule.
Is there anything on the horizon for targeting RAS mutations, particularly HRAS?
Oh man, they're working on it. It's something that it's being worked. They're working, but it's not easy. It's not as red. It's not at the other mutations. So a specific RAS, they're working on it, but I don't know how much time it's gonna take. I hope it comes soon, as every one of you.
Why go after the total thyroidectomy and central compartment fast? If it is wait and see for recurrent surgery.
No. Remember that what I said was after the initial surgery had been done. So it's okay at the initial point. Once you get the diagnosis of medullary thyroid cancer, yes, you should act upon that fast, right? You should do the total thyroidectomy, the lymph node dissection. That should be done fast. What I meant to say is after having your initial neck surgery, if you had recurrence of disease in the neck, that was what I was referring to. I hope I'm being clear about this because I see they're the same questions kind of.
All right. Why do you need to wait 3 months to take your calcitonin after the initial surgery?
Oh, okay. Yes. Because of the calcitonin half-life. So just that's the amount of time that your body takes to produce calcitonin when you had your thyroid gland. So once the thyroid gland gets removed, we need to wait 3 months for that form calcitonin, your body gets rid of it so that we know how your calcitonin looks without having a thyroid. That first post-operative calcitonin, the one that we obtained 3 months after surgery, is really important because it basically tells us if all tumor cells were removed or not. If we remove all your thyroid, all the tumor in the neck, and your calcitonin goes down to 0, that means all the tumor is gone, right? But if we see a calcitonin that is above the upper limit of normal, then that tells me that this is likely malignant cells that are still remaining in the neck. And this value comes the lowest value that you've ever had. It's like your new baseline for calcitonin. And that new baseline of calcitonin, we have to get it 3 months after the surgery because we assume that the calcitonin that you have produced from when you were having a thyroid is now gone. And we are seeing now how you look without having a thyroid.
Is ultrasound sufficient to show lesions in trachea and esophagus?
That's a great question. No. To look lesions into the trachea, into the esophagus, you need a CT of the neck with contrast. The ultrasound is not able to see lesions that are in the lumen of the trachea.
Fasting from alcohol and spicy foods for 14 days before calcitonin CEA blood draw necessary.
14 days? No. I think, it's probably enough, like 3 days before. But I don't think 14 days. And that's just being cautious, 3 days. We usually say the night before.
Okay.
Thank you for that question.
Yeah. So Lucy came back. She was the one who asked about the hot flashes. She says, is there some endocrine testing for hot flashes?
Yes, there is. And that's what I was saying, that your endocrinologist should rule out the endocrine causes first before sending you to the primary care doctor to see other reasons. But yes, there are.
Okay. During my total thyroidectomy, I lost all my parathyroid glands. What can help with symptoms of hypopara?
Okay. Well, when that happens, you have to take calcitriol, which is the active form of vitamin D. You also have to take the normal over-the-counter vitamin D, and you have to take higher doses of calcium every day. Now, I do have to say that the calcitriol, the active form of vitamin D, and the vitamin D are very important because you need vitamin D in your body in order to absorb the calcium. So you can take as much as calcium as you want, but if you don't have the active form of vitamin D, you're not going to be able to absorb it from your intestines. So all those three, you should be taking all those three.
Thank you. I did super catnib 3 months neoadjuvant to surgery. I was stage 4C. Drugs significantly reduced tumors. They could hardly be seen on the ultrascan. CEA now 6.6, calcitonin is under 100. So I guess that was just a comment.
Yeah, I'm very happy you're having that good response. And I hope everything goes well with your surgery.
Okay, Nell's asking, when recurrent disease is being monitored, how often
Karen,
does...
Karen, I'm sorry to interrupt you, but I just want to explain something to the audience about this comment, right? There is a clinical trial that is going on right now. I don't know all the places where it's happening, but you can look that in the internet. But this is called neoadjuvant treatment, where the RET inhibitor, selpercatinib or pralsetinib, are given before you have your first surgery. And this is something new. I didn't talk about this. And basically the idea behind this is if you have a big tumor in your neck, where that is gonna cause a big injury to your neck, there is high risk of when you try to get it out, you will have hypoparathyroidism, you can get hoarseness of your voice. It's a big morbid surgery. When this happens, then there's this clinical trial going on where you start giving the tyrosine kinase inhibitor, selpercatinib or pralsetinib, the selective RET inhibitors, before going into the surgery. And this is with the idea of reduce the tumor size so that when the surgeon goes to operate on your neck, you have less chances of going into hypoparathyroidism, hoarseness of your voice. So it reduces the morbidity of the surgery. And usually you take it for 3 months before the surgery, and then they go and operate on your neck. Thank you for commenting that.
Okay. Okay. Can you tell me, from Lucy again, can you tell me what test to ask for? She she saw her endocrinologist last week and she didn't recommend any tests. So she wants to know what test she should ask the endocrinologist for those hot flashes.
Okay. So the first test that comes to my mind is to get an FSH and LH. Then other endocrine stuff that cause that are pheochromocytoma, that's within the differential. As I mentioned, just postmenopause symptoms can cause that. Other things can be being hyperthyroid can cause that. Medullary thyroid cancer can cause that, but in her case, I think she said that her calcitonin, if anything, is stable. There haven't been any change. Something called carcinoid syndrome, which I don't think you have. With that, you have to do a 24-hour urinary collection and look for a particular substance in your urine. Those are the primary ones that should be looked for. Yeah. But in your case, I will make sure you're not hyperthyroid. That's the common reason, right? You're taking thyroid hormone, making sure you're not taking more dose than what you need. And then check about postmenopause symptoms.
Thank you. From an anonymous attendee, is a CT of the neck with contrast the best imaging for the neck?
I think if I want to answer straightforward, I would say yes. CT with contrast is the best imaging for the neck. However, there are indications on when to order it. Because if, let's say, as I mentioned, your calcitonin is less than 150, right? I am unlikely I'm gonna send a CT of the neck with contrast because you don't need it. We can find disease with the neck ultrasound, and you won't be exposed to unnecessary radiation from the CT scans. Yes, so if I think that your tumor is maybe invading into the airway, invading into the esophagus, or your calcitonin is more than 150, I will be more prone to order a CT of the neck. But if those are not the cases, then I'll rather have an ultrasound of the neck and avoid exposing you to radiation.
Okay, from now, when recurrent disease is being monitored, how often does this take place?
When recurrent disease is being monitored, how? Okay. So that depends on how active, how rapidly growing your disease looks, right? If I see tumor markers that are rising very fast, I will like to see you back in 2-3 months. If the tumor markers are not rising in a fast fashion, I will see you every 6 months.
Okay, thank you. Would one remaining parathyroid be the cause of
one more thing. Sorry, Karen. I'm sorry, Karen. Also, that's when talking about the tumor markers, but also if I do the imaging studies and I see that the lesions are growing fast, putting aside what the tumor markers look like, if I see that your lesions are growing fast, then I will also like to see you more frequent. So every 2-3 months as opposed to every 6 months.
Okay. Would one remaining parathyroid be the cause of constant low vitamin D levels?
No. No. Well, there are 2 types of vitamin D, but in general, I would say the answer is no.
Okay. With sporadic MTC, do you need to check chromogranin A or B?
No. We check calcitonin and CEA.
Okay.
Chromogranin is not a necessary tumor marker to check.
So the last question for this session, asking Dr. Vodopivec, do you see patients, and if so, where are you practicing?
I'm practicing at the University of Alabama at Birmingham.
And are you taking new patients?
Yes, I am.
Okay, there
Yes,
you go.
and I
Casey.
would love to see, you know, I would love to see you in the clinic and have you as my patient. Yes.
Okay, so I've got one more question. I think especially when I was newly diagnosed, I had a hard time waiting 6 months. I think it is okay to ask to have an appointment sooner for anxiety.
Yes, or depending on the scenario, right? Because only your doctor knows how your disease is progressing, yeah, how your disease is behaving. So let's say I have a very anxious person, anxious patient, and I understand if you're anxious. I mean, we're talking about cancer. It's not something to minimize. But if I see that you're very worried about it, yes, I would see you maybe one time sooner than anticipated to kind of give reassurance and explain to you the situation and how things are going to give you calm. If I see that this is not enough and you know are still being anxious about it, then I will probably just go back onto checking that patient according the guidelines, you know, as expected. I won't probably see you sooner. But if I see that your disease is progressing fast, I will have no hesitancy in seeing you sooner because there's a real reason why to be worried. Another thing that comes to my mind is I will give you a call, you know, if you let me know I'm anxious and, you know, I will give you a call and again, reassure you of your condition and what's going on and if there's a need or not to be worried. Yes, I won't minimize how you feel, basically.
Well, doctor, thank you so much. It was very helpful. And we're happy to have you as part of our advisory team here in the Medullary group. I think you explained it at a good level for anybody who's new and for those of us who've been around a while, just reinforced some information. So thank you very much for your time.
Thank you very much, Karen, and thank you everyone who attended this session. Have a nice day.
Thanks, everybody.